Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Brian Waterman, a sports and shoulder surgeon at Wake Forest University, North Carolina. Brian, how are you?
Hey, doing great, Peter. Great episode today. Thanks for joining us.
Well, I'm excited for us to do this. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeon Society, University of Utah, Wake Forest University, or the institutions of any of our guests. Okay, today we have an episode on a hot topic in shoulder surgery, which is the management of glenoid deformity in a reverse total shoulder arthroplasty. And this is an area of controversy where similar cases can be managed very differently by different surgeons. And to discuss, we've invited several national experts. So first, from New England Baptist in Boston, we have Dr. Andrew Jawa. Andy, welcome to the podcast.
Thank you so much for having us. I appreciate it.
Next, from Duke University, North Carolina, we have Dr. Christopher Klifto. Chris, welcome to the podcast.
Thank you, Peter. Thank you, Brian. Huge fan of the podcast. Thank you for having me.
And then finally, from the Rothman Institute in Philadelphia, we have Dr. Joe Abboud. Joe, welcome to the podcast.
Thanks for having me, Peter and Brian.
Okay, so let's start at the beginning. And I want to start with a clinical scenario. So you're facing an elderly patient with a massive irreparable rotator cuff tear and pseudoparalysis. So I think hopefully all of us agree this is a reasonable patient for a reverse total shoulder arthroplasty. And let's say there's no glenoid deformity. It's a normal glenoid. And the reason you're doing the reverse is not for arthritis, not for glenoid deformity. It's solely for an irreparable cuff tear. And the question I want to ask each of you is, for this patient with no glenoid deformity, are you routinely using a bone graft or an augment, or is this a patient that gets a standard base plate? So Andy, how would you approach this patient?
Yeah, so I would typically have preoperative planning. And sometimes it's interesting that these patients who have a normal glenoid actually are superiorly tilted a little bit, especially in rotator cuff arthropathy or massive cuff tear without significant erosion, which is interesting. But say they're 10 degrees superiorly tilted on preoperative planning and maybe 5 degrees retroverted. I'm planning to use an off-the-shelf base plate. I will tilt down to try and get to 0, maybe 1 superior, 2 superior, or definitely down to around 0, so decreasing about 10 degrees of inclination to minimize instability, which I think is one of the highest risk in this patient. Version, I'll just keep it where it is, and I don't want to over-ream. These patients have really soft bone because they haven't been seen a lot of force, and so I won't ream as much. I'll try and get with my base plate 50-60% coverage. Fixation is key. So that's how I'd approach that. I do go a little bit bigger to try and minimize instability. I try not to go so tight to minimize stress fractures, but that's sort of a simple overview.
Okay, what about you, Chris Klifto?
Oh, Peter, we actually talked about this a lot, and I learned a lot of my technique from you. I use an augment almost every time for this patient, and the reason is not only do I want to correct the inclination, like Andy said, these like to, if they're going to dislocate, kind of dislocate lateral and superior. And the ones with the irreparable rotator cuffs, I get more concerned with for dislocations and rotator cuff arthropathy. So having an inclination built in with my wedge is the objective I'm trying to achieve. And not only that, the wedges also usually lateralize a little bit more. That gives me a little bit more stability for these patients, and that makes me a little bit more comfortable leaving the operating room.
All right. So we have one vote for no augment, one vote for augment. Joe Abboud, come in here as our tiebreaker. How would you approach the glenoid in this patient?
So similar to what Andy said, as far as I don't typically use an augment in this situation, and I'm trying to get them back to neutral inclination version. And if I need to, I will. I don't plan every one of these cases. I mean, this is a fairly straightforward glenoid on X-ray, and no significant erosion evident on X-ray. I would usually get a CT scan, but I won't say I plan every one of these. It's sometimes fellow dependent, to be honest. I mean, I tend to go over it with them, but I don't sit down and do it with them. That's shame on me. But the reality is, with the system that I use, I feel like I can get enough of a bit of a tilt with my base plate and the amount of lateralization with my glenosphere, that should provide good stability. I do worry about lateralizing it more than that with built in on your base plate and potential for acromial stress fracture. But yeah, these are a little bit worse for stability compared to the other patient population that we're dealing with.
All right, so let's
Peter,
flip
may
the
I make a
script.
comment, or Brian?
Go ahead. Yeah, Andrew, please.
Just to sort of clarify, I would say that I'm not opposed to augments. I think augments work. I think we all learn what to do to get, the inclination we want with the system we have, and we adapt. And I think sometimes we are not afraid to say that, each of our systems have things that work well and don't work well, and we use what we have and we adjust accordingly. And so if we have an easy to use augment, I think we use that. If it's easy to use a graft, we use that. If we can adapt, I think whatever it takes to get to that position where you get ingrowth and fixation, a lot of good surgeons can get to that in different ways.
Yeah, I agree with you wholeheartedly. I think the next scenario probably will tease it out even more. So if we flip the script then and we start talking about that individual with cuff tear arthropathy, kind of that more superiorly based wear, if you want Favard E2 or E3 glenoid, let's go in reverse order. Chris, tell us how you're managing that deformity and what are you doing for this bony deficiency?
I'm going to have a pretty similar answer every time. So I hate to be a spoiler, but it's usually an augment for most sort of pathologies, and this one's no different. We actually just did a study, and Peter actually helped us with it. And Exactech was nice. I have no affiliation with Exactech, but they were nice enough to allow us to use their database looking at GPS navigated patients, and we defined our cohorts as less than 10 degrees of inclination and less than 15 degrees of retroversion. And the reason why we did that was probably our best definition of a normal glenoid that may or may not need an augment, the one that's a tweener, yes or no to augments. And we actually found that patient, Brian, that you're just describing, did somewhat better with the augments. We found that surgery time was better, PROs were better, range of motion wasn't any different, complications weren't any different, and we were able to, the people who use this system were able actually to plan more reliably with an augment, not in superior tilt than the ones that use a standard base plate. So after doing that study, taking less bone, shorter surgery time, more accurate planning, I've switched most of my practice to an augment.
Joe, maybe I'll pass it off to you and I'll add additional question on top of that. Is there ever a scenario where you're using autogenous bone? You have the humeral head right there. Is there any scenario where you're using that now, or are you preferentially considering just metal augmentation with your base plate?
So yeah, like you described, the Favard E3, it's a primary surgery. I'm oftentimes, the contour of the humeral head is very nice for that. Fits right nicely with the screw base plate that I use. So I do use that quite a bit. The system that I currently use does not have augments, so I've not been somebody that's traditionally used a lot of metal augments. And in situations where I have a lot of bone loss, I'm using more in the custom scenarios. But for what I would consider reasonably straightforward deformity, I will use bone, whether that's oftentimes autograft versus allograft, depends. If it's a severe deformity, then I'm getting a custom. To just Chris's point, I think it relates to that specific system, though. So I guess that there's so many different variables, right? When we start looking at every system, that I guess if you're using that particular system now in your cases, then it makes sense to use augment almost all the time. But otherwise, it's not apples to apples, really.
Yeah, I agree with you. I think sometimes it's hard to be agnostic to your implant system, because I think there are going to be certain things that are going to be afforded by your unique arthroplasty, portfolio. Um, we've seen definitely a transition towards greater utilization of metal augments, but Peter and I both trained under Greg Nicholson. Horseshoe grafts were very common, particularly with those eccentric wear patterns. So I'm curious, Andy, what are your thoughts on how you manage this scenario?
Yeah, I mean, I think they echo some of what Joe said and some of the thoughts I said before, which is I think we just adapt to our different systems. And if we, I have a system that right now I can actually use augment on the fly or just use a regular base plate. And sometimes I do, and sometimes I don't. And before I use bone graft. And again, my goal was to tilt it down. We can talk a little bit more about how far, but I think we as surgeons get to a place the way that we know how to, and we adapt accordingly. I'm not sure if this is exactly the same study I'm thinking about, Chris, but if it is the one, I that was the one that I there was a lot of patients in the augment group and few patients in the non-augment group. I might be thinking of a different study, but there's a similar one. And again, sort of reiterating maybe what Joe said, it seems like it could have been a proxy for other issues. And so I think it's hard to actually say that patient-reported outcomes will be better with an augment because there's so many other factors. I have trouble believing. I think it may be a measure of something else, whether it's the patient or the surgeon or some aspect of the system. But I agree with inclination, and how we get there just varies by how we use our system.
I think you're totally right, Andy, that the evidence we have on this subject is largely non-randomized. And in non-randomized studies, there's so much residual unmeasured bias, even if you try and match the patients, that really makes it challenging for us to know, are we comparing apples to apples, as you say. One of the things I wanted to ask you about, you mentioned your system, you have an on-the-fly augment you can use. That I think probably makes a lot of sense if you have eccentric wear. You have wear in one quadrant of the glenoid, whether that's, your superior wear with cuff tear arthropathy, your posterior wear with glenohumeral osteoarthritis. How are you handling the patient with medialization? So I think we've all seen this patient. They've got severe medialization, but there's not necessarily a lot of inclination or version deformity. It's just that they've had a lot of medial wear. They've got that A2 glenoid, that E1 glenoid. So how are you addressing that, Andrew? Are you bone grafting that patient? Or are you trying to fix that all on the glenosphere side? What is your strategy there?
So I think I'm in an island on lots of ways that I think, and this is one of those islands where I hear a lot of people, and I may be in an island where it's a bad island, but this common phrase or dogma that people say, hey, it's medialized, so you have to sort of restore the joint line or, reconstitute that bone, otherwise they're going to be unstable. I think maybe that comes from, our approach to a knee or a knee replacement, but it never made sense to me because I find some of these patients like really tight and hard to reduce. And so my number one goal is simply to get fixation and ingrowth. And ironically, the more lateral you make it, or the more you restore joint line, I think the more forces and torque you're putting on your implant ingrowth, bony ingrowth interface. So I take it the same way. My main goal is to try and get fixation. If it's really eroded and it's a small area, I'll use a PSI to try and find that. Some of these really medialized glenoids actually have a lot of bone, and I'll just find the bone and determine tension on the humeral side. And I do differ by gender, or as you have taught me, Peter, height of the patient. So a little bit different than some people who really want to sort of restore joint line.
God, that's a super interesting response. And I don't know what the right answer is. Joe, tell us the right answer. Do we need to get back to the premorbid joint line?
Well, the premorbid joint line developed over presumably at least a decade or so. So it's been a gradual change in the length-tension relationship with the soft tissues. So I think realistically, going back to the premorbid joint line is a bit unrealistic, or puts a lot of tension on the soft tissues, not the least of which are the nerves. So to me, going back to the premorbid joint line in those situations probably isn't realistic. I think what you're trying to do is establish a good length-tension relationship to create good moment arms for the supporting musculature without putting too much stress on the scapula and the acromion. But I was thinking when Andy was talking that, he has a kickstand now, and, once he comes out of the folding chair, then he'll be using the folding chair because he just needs more pegs, because he can then put 4 kickstands, and then you can lateralize to that. Just kidding, Andy. Just kidding. Friendly banter. By the way, Chris, Andy and I, before this call, said we were going to haze you, so we're ganging up on you. Everything you say, we're going to disagree with.
Well, he right off the bat, he just called my research unethical. So I can't believe the host let that go. Come on, guys.
Understand.
What about you, Chris Klifto? I mean, do you think you need to get back to the premorbid joint line? Are you just using the superior wedge for every case, and you use that to also restore your lateralization in these kind of medialized patients?
It's such an interesting question. And Andy, I'm going to ask you kind of what you think too, because of all the amazing work you've done with stress fractures of the acromion. But, it's interesting, right? Because these patients are often contracted, and you want to restore the joint line, the premorbid glenoid, but also at the same time, you want to overtension. The problem with augments, like I said, is oftentimes you over lateralize, and these patients have not had the same stress on the acromion. These increased lateralization wedges, I know, Andy, are they associated with acromion stress fractures? And should I be concerned about this?
So first, I would say, Chris, your work is amazing. I didn't mean to negate any of that, so I apologize regarding my comments previously.
I just want to make a note that I'm winning right now, because you two now hate each other, and I polarized both of you. It's perfect.
Inside the mind of
do augments lead to more stress fractures? I don't think we know. There definitely is some thought and some evidence that maybe over lateralizing, and what does that mean on the glenoid side, could increase the risk of stress fracture, or there's a correlation, let's put it that way. But implant factors, actually, in terms of odd ratio, was actually on the lower side of significant things. The number one things are patient factors, being a woman, being osteoporotic, having rotator cuff arthropathy, as opposed to OA.
First off, I love that Joe has already positioned himself to foment conflict among our participants. So, guys, you're falling straight into his trap.
We always fall into Joe's trap.
So we've kind of talked a little bit about some of the glenoid-based deformities, and I think we've kind of soft-pedaled around, more philosophical beliefs about how you approach this from time zero. I agree with you. I think this concept of global lateralization is definitely something to consider, but to get into the premorbid joint line probably is less relevant for the reverse scenario. Let's take it one step further, and let's talk about one of the hardest defects that we address, and that's in the revision situation. Oftentimes we're still seeing these patients that come in with a hemiarthroplasty with significant erosion. We obviously have limited options in terms of humeral head. Maybe let's start in the middle. Joe, what's been your approach to this patient specifically? And maybe you can navigate us through some of the tough points that I continue to struggle with in this patient population.
So just to be clear, Brian, we're dealing with a patient who's had an arthroplasty. It's a hemiarthroplasty, and we're converting them to potentially a reverse. Is that right?
That's right. That's right.
And they've had erosive changes in their glenoid that are pretty significant, and there's presumably most of the off-the-shelf components are probably going to be suboptimal for some of the defects here. Some of them will be okay, because a lot of times you'll get some posterior superior erosion, but you have good bone sort of central and inferiorly that you can get good base plate fixation in. But I think that even a worse scenario is you have some of these older polyethylenes that have been put in that have lost, lysis around them and wear, and you're dealing with these massive defects. And so, for them, and I think the technologies continue to improve to be able to take a CT scan and decrease the artifact, to be able to run it through the software of several companies and manufacturers now that can give you something somewhat patient specific to versus totally patient specific. That's my experience. Each company is a little bit different as far as how good they are in replicating the morbid anatomy for you, but that's very helpful because, let's say 5 years ago, I would go into that case and sort of try to figure it out on the fly and sort of see what the limits are. One of my mentors professionally, Mark Frankel, has taught us a lot about the alternative center line, and I've used that, and I think it's a very good technique to be able to get good fixation. But I think not everyone is Mark Frankel. I've been able to replicate it, but it's sometimes challenging to get that perfect positioning. So that's my long-winded answer to that. I hope that sort of helps a bit.
Yeah, that is. And Joe, just to dig in on that a little bit, for those that are less familiar, what's your approach to the alternative center line? Maybe you can walk through what are you shooting for? What level of fixation? What level of version is acceptable, do you think? Is there an upper limit?
The version doesn't concern me so much. They're usually fairly inverted. The base plate's fairly inverted in these situations. And so, once you've sort of, hopefully based on your preoperative CT, figured out, do you have bone in that confluence of the spine, the coracoid and the scapula there? If you have enough bone there, then, I think what you want to do, and I think that if you haven't done this before, having fluoro is not a bad idea. It's just going to give you an idea of your height, not necessarily if you're in the right spot. And, Mark talks about sounding it out, using a drill bit to sound out to make sure you're going to the opposite cortex and getting bicortical or far cortex penetration for, if you're using a screw-in type base plate. I haven't used it with a non-screw-in type base plate, so I think it's somewhat, you have to have a relatively monoblock system to make this work. And I think with this system, I think if you have at least 50 to 60% coverage, you're pretty good. In certain situations here, you may be using some bone graft and different types of glenospheres to potentially increase your surface area, which may improve your fixation. Again, this is level 5 evidence. But I will tell you, it does work and has saved me a couple times when I was really struggling with a revision. But again, you're probably doing and these days a lot of people are doing over 50 stems a year, but you've got to be doing a lot of these to really get comfortable with that anatomy and where you're targeting. And I think it's reasonable in these situations to make sure that you have a really good exposure on the anterior glenoid. So you can see the anterior glenoid neck. You can get your finger, past whatever soft tissue, subscap tissue there's still there. So you know what you can feel kind of what you're aiming for. And one thing that I've done more recently is if I'm struggling to really get a sense of the anterior glenoid, I will tenotomize the conjoint tendon. And if need be, repaired at the end. If not, let it fly.
Yeah, that's a novel approach, and I agree. I think that can sometimes obstruct your appreciation. Andy, in terms of other options, talk to me a little bit about this case scenario, but also through the lens of custom implants. What's been your experience with that, and any additional feedback you'd offer on that?
Yeah. So I feel so in this case scenario with a hemi that's eroded into the glenoid. Ironically, I actually find these cases, like Joe said, not too bad. It's the polyethylene wear patients, the TSA patients, that I find difficult because there's a lot of bone loss or uncontained defects. I actually find these hemis to do okay. They have good hard sclerotic bone. Um, Sometimes on preoperative planning, you can get version and inclination and have better sense of it with some of the programs nowadays, even with metal in the head. But I find that these patients can actually do pretty well off the shelf. I will admit I don't use a lot of custom base plates. I find that for me, off the shelf base plates have worked really well. I think the alternative center line has worked well, or allograft for contained defects or uncontained defects. I've used either autograft or two-stage with allograft. So I find this scenario works relatively well with off the shelf for me. If I can make a comment about if we're talking a little bit about version and inclination, in terms of retroversion, I agree with Joe. I don't think version matters that much. If you look at the literature, you probably get the best impingement free range of motion at neutral version. But if you look at some clinical papers, they pretty much show that whether it's the alternate center line, which is anteverted, or we have a paper that's greater than 15 degrees retroverted, it really doesn't seem to affect clinical outcomes. So I think version doesn't matter as much. We touched on inclination a bit. I just want to put a couple of points of thinking about it, which is I think we're not actually really good at measuring inclination postoperatively. And there's this dogma that we need to go to zero of inclination. And I'm not even sure what that means. I'm not sure we all even agree with that. I think you can be superiorly inclined a little bit. And so I think those measures are a little bit off. There is some data that Peter has shown that maybe have some slightly higher risk of instability if it's slightly superiorly tilted. But again, that was a medialized glenosphere. So I got a little off topic, but I think we don't really even have the norms of what we're trying to aim for at this point. And I think that just poses really interesting questions.
Yeah, I agree with you, Andy. The one caution I would have is that I think what you said about inclination is always also true of version, that I think our measurements of version on postoperative radiographs are maybe not as accurate or as we would like. I think you could make reliable measurements, but they probably are not the same measurements as if you were to get a post-op CT scan, and there's relatively few studies that have post-op CT scans to actually measure what the version of the component is. And
Absolutely.
Just as a caution to those listening, I have sometimes wondered whether anteversion is better tolerated with an implant that is more lateralized on the glenoid side. And anteversion, I think, is often relatively poorly tolerated with a more medialized glenoid component, because I think that you're more likely to encounter conflict with the coracoid. And there was a super interesting study that the Sharks group did, led by Pat Denard, Patrick Rice, that showed that there is actually a difference. There's actually an association between the patient's clinical outcome and the distance between the glenosphere and the coracoid measured on the axillary radiograph. And I think that's about that same kind of anteversion conflict concept, and that putting the glenoid component a little bit more posterior and more retroverted gets you better impingement range of motion relative to the coracoid, especially as the patient comes into more internally rotated positions. Has that been
That makes a
your
lot of
experience?
sense, Peter.
Yeah. Go ahead.
Yeah, I should think about that more, but I saw that study, and I agree. We need to know more, and that does ring true with how I was thinking. So great point.
How about you, Chris Klifto? How what's been your experience with custom components, and then how are you approaching the patient with kind of like the post-hemi arthroplasty kind of wear pattern?
Well, I'm okay with the post-hemi arthroplasty wear pattern. Like Andy was saying, that's one of the more benign revisions I do. Anything more than that, I just send it to Brian, who's right down the street from me. So I'm sorry about that, Brian. Sorry to influx your clinic with complicated patients. But the truth is, I echo what Andy was saying. I get concerned with the poly that has a keel in it. And when I see that for my preoperative CT scan, then I start thinking maybe just standard off-the-shelf components may not work. Most of them can be done with wedges or half wedges, and I've had good success with that. You and Bob have a really nice technique about using I saw your videos with the femoral head allograft and impacting with a long post and longer screws, and that works very well too. But if I see that keel, especially if it's medialized and uncontained, I have a pretty low threshold to kind of jump to a 3D custom implant. I've had pretty good success with that. To your point about the anteverted glenoid, Peter, I want to ask you a question though. You also have done some really nice work on looking at anterior shoulder pain and conjoint irritation. So when you antevert your glenoids and your base plates, do you get concerned about having contact with the conjoint and anterior shoulder pain?
Yeah, I absolutely worry about that, about impingement of the conjoint and the anterior portion. I do think, though, that that's very dependent on the geometry of your component. I think that that's less likely with a more distalized humerus. So if you're using a traditional Grammont, a 155 where the component is sitting under the glenosphere, I think you have less of that issue than if you're using a 135 where the humeral component is sitting lateral to the glenosphere. Where then I think it's easier for you to impinge on the conjoint, and particularly the coracoid. But I think that, again, that depends on how lateralized you are. It depends on where you are in translation, anterior, posterior. So Chris, you talked a little bit about how you worry more if you see the keel, if it's a prior there's a prior glenoid component. Let's talk about that scenario. So often, if there's a prior base plate and it's been taken out for infection, or if there's a prior loose anatomic glenoid component, how are you addressing that patient, the patient with a more cavitary defect, or even maybe a component, maybe an uncontained defect in that revision glenoid? Like, is that still an augment for you, or is that a situation where you're more tending towards bone graft or custom component? How do you approach that, Chris?
They're all different, and that's what makes this so much fun, and why shoulder arthroplasty is just one of the coolest things in medicine. Is every one you have to think differently and critically about. The patient that has a medialized, uncontained cavitary defect, and we all know what that looks like. There's almost no fault. Maybe there's some inferior glenoid. It's uncontained. That patient gets usually a custom for me. If they have the majority of their rim intact and it looks like there's some good bone and it's not medialized, then I'll probably do the femoral head allograft and try and lateralize through that. And if there's just part of the glenoid that's missing in the rim and I have good bone, then I'll probably just use a wedge or a half wedge. And that's usually my algorithm for treating these patients, besides setting with Brian.
Mm-hmm.
What about you, Joe? I mean, this is obviously the worst clinical situation, the one that we kind of sweat the most about. How are you approaching the patient who comes in with a contained or an uncontained defect from a revision of a prior glenoid component you're revising to reverse?
Yeah, that's for sure very challenging. And in the last 3 years, I have worked more with the custom base plates and sort of gradually pushed the envelope to more and more bone loss, worse and worse situations where there's more artifact. I just recently did a case where I had a failed base plate with broken screws, base plate migrated, windshield wipe ring, been broken for 6 to 9 months, and did a custom. And obviously nothing ruined surgery like follow-up, but it went exceedingly well. So again, level 5 evidence makes me think this technology is going to get better for these really catastrophic situations where a 2-stage operation is just a statement for us in some ways. For the patient, it's a 6 to 12 month journey of disability. And so if you can turn that into a 1-stage, barring infection and barring a a virulent organism, then you're giving them a lot more quality of life. So it's something to think about. They're obviously much more costly.
And then what about you, Andy? As you approach that revision patient, the patient we all sweat about, what is your rubric? What is your paradigm or your usual guidelines you use?
Yeah, so I think at this point I feel contained defects. Most of the time I can do that in one stage. I pack it either with, depending on the size, cancellous graft, and you can really pack it deep and get it pretty dense, or I'll use femoral head that I shape, and I get fixation on the far cortex. And I would say the vast majority of the time I feel comfortable doing that in one stage, and that's done well. I've had failures, but that's generally the way that I approach that. For the uncontained defects, which are really hard, and there's uncontained and there's really uncontained. Sometimes there's a little bit of a rim there. I am often, I talk to the patients about various scenarios where, in ideal world, I would love to do it all in one stage with femoral head allograft or alternate center line. I'll sort of base that off my planning. If I think I can do alternate center line, I'll do that, plus minus graft. Other times I will actually consider two-stage, and I'll consider a hemi-reverse in that scenario. I don't like putting in that definitive sort of hemi implant in there and then putting graft on the glenoid and coming back, because I think when the stem's in place, it makes it hard to come back to do the secondary procedure. And I agree with Joe, 2 stages, the tissue gets woody, it becomes harder to manage. But if I don't feel like I can get the fixation, I have a lower threshold to do a hemi reverse. And then if I'm like, I can't do this, or I know ahead of time, I'll do a custom, or I'll take out everything, put a prostalac in, get a better CT to do a custom. I do agree with Joe. I want to try and minimize 2 surgeries, but I've unfortunately done this like Joe long enough that I've had failures of one stage, and I really just want them the best chance to have a long-term success. I really do worry about ingrowth on these base plates, even though initial fixation can be good. Ingrowth can be tough in this sort of sclerotic bone.
Well, there's just a ton of words of wisdom there. Certainly one of the things that I thought was really interesting to hear all of you say is that it seems like there's a great mixture that people are using, where people are using grafts in situations and augments in other situations and custom base plates in other situations. And it sounds like that's one of the reasons, why you could go to fellowship with one of you guys, is to learn what are the places where each of these apply. And then also there's a certain amount of art to it that, you could approach the same case differently, and probably, as Brian Cole once told me, there's more than one way to get this right. I wanted to thank each of you for coming on and sharing your wisdom with us. It's been a tour de force, and we really appreciate your time. And the listeners, I think, are going to get a huge amount out of this. So thank you each for coming on. Well, that's all the time we have for this podcast. Thanks so much for our guests. For all of our shoulder number listeners out there, don't forget to subscribe. And for Brian Waterman, I'm Peter Chalmers, and we will see you next time.